This is Lecture 12, Toxicology, Alcohols, Opioids, and Antidotes. The ED toxicology mindset is ABCs and glucose first. Recognize the toxidrome, give the antidote when it matches the physiology, and involve poison control early. The right antidote for the wrong toxin causes harm. Fomepizole is the wrong answer in a mixed overdose. The objectives are these. First, recognize the major toxidromes. Second, manage opioid toxicity with ventilation and naloxone titration. Third, recognize and treat toxic alcohols with Fomepizole and Dialysis. Fourth, apply the Tylenol nomogram and NAC. Fifth, manage salicylate toxicity with bicarbonate and avoid catastrophic intubation. Sixth, treat calcium channel blocker and beta blocker overdose. Seventh, recognize sodium channel blockade and treat with bicarbonate. And eighth, avoid the classic toxicology board traps. The ED toxicology mindset is structured. ABCs and glucose first. Toxidrome recognition guides early therapy. Decontamination is selective, not routine. Activated charcoal is rarely indicated and dangerous without airway protection. Poison control consultation should happen early. Antidotes save lives when matched to physiology and cause harm when matched wrong. The right diagnosis with the wrong sequence kills. The major toxidromes are recognizable patterns: sympathomimetic, hypertension, tachycardia, hyperthermia, diaphoresis, agitation, mydriasis. Examples: cocaine, methamphetamine. Treat with benzodiazepines. Anticholinergic, tachycardia, hyperthermia, dry skin, mydriasis, urinary retention, altered mental status. The ITE buzzwords are hot as a hair, dry as a bone, red as a beet, mad as a hatter, blind as a bat. Examples: diphenhydramine, atropine, scopolamine, tricyclic antidepressants. Treat supportively, physostigmine selectively, and never in TCI overdose. Cholinergic, salivation, lacrimation, urination, defecation, GI distress, emesis, sludge, meiosis, bronchorrhea, bradycardia. Examples: organophosphates. Treat with atropine and pralidoxime. Opioid, respiratory depression, meiosis, decreased mental status. Treat with naloxone. Sedative hypnotic, respiratory depression, CNS depression, often without meiosis. Supportive care. Fomepizole is rarely used and is a classic distractor in mixed overdose because it can precipitate seizures. Opioid toxicity kills through respiratory depression. The immediate life-saving intervention is ventilation, not naloxone. Open the airway, bag mask ventilate, suction as needed. Once breathing is supported, naloxone reverses the receptor effect. Naloxone is titrated to adequate ventilation, not necessarily to full wakefulness. In opioid-dependent patients, complete reversal precipitates withdrawal, agitation, vomiting, and may cause non-cardiogenic pulmonary edema. The board principle is to oxygenate and ventilate first, then naloxone. Naloxone dosing depends on the situation. If the patient is opioid-dependent but breathing poorly, give small intravenous doses of 0.04 to 0.1 milligrams, titrated to adequate respirations. If the patient is apneic and IV access is delayed, give larger intranasal, 2 to 4 milligrams, or intramuscular doses, 0.4 to 2 milligrams. For long-acting agents like methadone or buprenorphine, or for sustained release preparations, consider a naloxone infusion at 2/3 of the effective bolus dose per hour. Observation duration depends on what was taken. Short-acting drugs may be discharged after 1 to 2 hours of stable monitoring post-reversal. Longer-acting ones need extended watch. The board concept is recurrent toxicity when the drug outlasts the antidote. The classic mimic on the boards is fentanyl with xylazine adulterant. Sedation persists despite adequate dosing because that adulterant is an alpha-2 agonist, not an opioid. Support ventilation, do not chase the dose. Toxic alcohols are board favorites because the lab pattern evolves. The classic patterns are methanol, ethylene glycol, isopropanol, and ethanol. Osmolar gap appears early because the parent alcohol is osmotically active. Aniongap, metabolic acidosis appears later as the parent is metabolized to toxic metabolites. Methanol metabolizes to formic acid, causing visual symptoms and blindness. The ITE buzzword is snowfield vision. Ethylene glycol metabolizes to glycolic acid and oxalic acid, causing acute kidney injury and calcium oxalate crystals in urine. The buzzword crystal shapes are envelope and needle. The differentiator is mud piles, is the high anion gap mnemonic, and both methanol and ethylene glycol live there alongside salicylates, lactate, DKA, uremia, propylene glycol, and isoniazid. Isopropanol metabolizes to acetone, causing ketosis without anion gap acidosis. Ethanol metabolizes to acetic acid through acetaldehyde. The board concept is that early presentation shows osmolar gap, later presentation shows anion gap with declining osmolar gap as the parent is consumed. Fomepizole blocks alcohol dehydrogenase and prevents formation of toxic metabolites of methanol and ethylene glycol. Dose is 15 mg per kilogram intravenous loading dose, then 10 mg per kilogram every 12 hours for 4 doses, then 15 mg per kilogram every 12 hours until alcohol level is below 20 mg per deciliter and patient is asymptomatic. Indications include suspected methanol or ethylene glycol with concerning history, elevated osmolar gap with anion gap acidosis, or measured level above 20 mg per deciliter. Ethanol is an alternative when the antidote is unavailable. Dialysis is indicated for severe acidosis, end organ injury, high levels, typically above 50 mg per deciliter for either alcohol or clinical deterioration. The board trap is waiting for a confirmatory level in a crashing patient. Tylenol overdose is dose-dependent and time-dependent. Single acute ingestion. Draw a 4-hour post-ingestion level and plot on the Rumack-Matthew nomogram. The treatment line at 4 hours is approximately 150 micrograms per milliliter. Above the line, treat with N-acetylcysteine. NAC dosing intravenous. 150 mg per kilogram over 1 hour, then 50 mg per kilogram over 4 hours, then 100 mg per kilogram over 16 hours. Total 21-hour regimen of 300 mg per kilogram. Oral NAC, 140 mg per kilogram loading, then 70 mg per kilogram every 4 hours for 17 doses. Indications outside the nomogram include unknown timing with a detectable drug level, evidence of hepatotoxicity, elevated transaminases, concerning history with delayed presentation, or chronic supratherapeutic dosing. The board trap is drawing the level before 4 hours and being falsely reassured. The next step question is when to call the transplant center. King's College criteria, arterial pH below 7.3 after fluid resuscitation, or the triad of INR above 6.5, creatinine above 3.4, and grade 3 or 4 encephalopathy. Salicylate toxicity is dangerous because patients compensate with hyperventilation, producing a mixed respiratory alkalosis and metabolic acidosis. Symptoms include tinnitus, tachypnea, fever, vomiting, and altered mental status. The ITE buzzword is tinnitus in a patient with mixed acid base, primary respiratory alkalosis layered on primary anion gap metabolic acidosis. That mixed pattern is the giveaway. Treatment is sodium bicarbonate to alkalinize blood and urine. Goal urine pH above 7.5, goal serum pH around 7.45 to 7.5. Bolus 1 to 2 milliequivalents per kilogram, then run an infusion of 3 ampules in 1 liter of D5W at 150 to 200 milliliters per hour. Replace potassium aggressively, since hypokalemia prevents urinary alkalinization. Dialysis is indicated for severe acidosis, altered mental status, pulmonary or cerebral edema, renal failure, levels above 100 milligrams per deciliter acutely, or clinical deterioration. The board catastrophic trap is intubating a salicylate poison patient and underventilating. A drop in minute ventilation worsens acidemia and drives the toxin into the brain, causing herniation and death. Calcium channel blocker and beta blocker overdoses cause bradycardic shock. Calcium channel blockers, dihydropyridines like Norvasc cause more vasodilation. Non-dihydropyridines like verapamil and diltiazem cause more bradycardia and AV block. Beta blockers cause bradycardia, hypotension, and sometimes hypoglycemia, especially with propranolol. The lab nuance is that calcium channel blocker overdose classically causes hyperglycemia because insulin release is calcium dependent. A high glucose in a bradycardic shock patient should trigger CCB on your differential. Treatment is layered. Step 1. Calcium chloride 1 gram or calcium gluconate 3 grams intravenous. Repeat as needed. Step 2. Vasopressors, typically norepinephrine and epinephrine. Step 3. Glucagon 5 to 10 milligrams intravenous. Better evidence for beta blocker overdose. Step 4. High-dose insulin euglycemia therapy. Regular insulin bolus 1 unit per kilogram, then infusion 0.5 to 1 unit per kilogram per hour with concurrent dextrose to maintain euglycemia and potassium monitoring. Step 5. Lipid emulsion therapy for refractory cases. Step 6. ECMO for catastrophic refractory shock. Poison center involvement is high yield. Sodium channel blockade produces wide QRS, right axis deviation, terminal R wave in lead AVR, seizures, hypotension, and arrhythmias. The ITE buzzword is a terminal R wave greater than 3 millimeters in AVR. That single finding predicts seizures and arrhythmia better than QRS width alone. Tricyclic antidepressants are the classic cause. cocaine, diphenhydramine in massive overdose, certain antiarrhythmics, procainamide, flecainide, and other agents can also block sodium channels. Treatment is sodium bicarbonate 1 to 2 milliequivalents per kilogram intravenous bolus when QRS is greater than 100 milliseconds or the patient is unstable. Repeat as needed. Goal: narrow the QRS, raise the blood pressure, and reduce arrhythmia. Avoid type 1A and 1C antiarrhythmics, which further block the channel. Avoid physostigmine in tricyclic toxicity, can precipitate seizures in asystole. Treat any seizures with benzodiazepines. The board concept is bicarbonate for this physiology, regardless of the specific agent. Digoxin toxicity causes a wide variety of dysrhythmias. The classic finding is bidirectional ventricular tachycardia. Other findings include atrial tachycardia with AV block, junctional rhythms, and high-grade AV block with ventricular escape. Acute toxicity may cause hyperkalemia from sodium-potassium ATPase inhibition. The electrolyte lab nuance is that potassium above 5 in acute overdose is the lethality marker. It predicts mortality better than the drug level itself and is a Fab indication on its own. Chronic toxicity is associated with electrolyte abnormalities, renal failure, and concomitant medications, amiodarone, verapamil. Treatment includes digoxin-specific Fab fragments, DigiFab, for hemodynamic instability, life-threatening arrhythmias, potassium greater than 5 in acute cases, or severe overdose. Dosing: empiric 10 to 20 vials for unknown acute ingestion. Calculate based on level and weight when known. Avoid calcium and hyperkalemia from digoxin. The stone heart theory, though recent evidence is mixed. Treat bradyarrhythmias with atropine. Pacing may be needed. Correct electrolytes. The toxicology board traps are classic. Naloxone endpoint is ventilation, not full wakefulness. Toxic alcohols should not wait for a confirmatory level in a crashing patient. Salicylate intubation can kill if minute ventilation drops. Early Tylenol levels, before 4 hours, can falsely reassure. Activated charcoal is dangerous without airway protection. Avoid physostigmine in tricyclic antidepressant overdose. It is the wrong answer in TCI toxicity. Calcium is contraindicated in hyperkalemia from digoxin in classic teaching, though recent evidence is more nuanced. Forgetting glucose in altered mental status, and dismissing isopropanol toxicity because there is no aniongap acidosis. Case 1. A 45-year-old presents with confusion, blurred vision, severe aniongap metabolic acidosis with pH 7.10 and an elevated osmolar gap. History suggests possible methanol ingestion. Give Fomepizole 15 mg per kilogram intravenous now. Correct acidosis with sodium bicarbonate. Activate dialysis for clearance. Call poison control. Folate may be given to enhance formate metabolism. The board trap is waiting for the methanol level confirmation in a deteriorating patient. Case 2. A salicylate poisoned patient is tachypneic, vomiting, altered, and progressively deteriorating. Start sodium bicarbonate 1 to 2 milliequivalents per kilogram bolus, then infusion. Goal urine pH above 7.5. Replace potassium aggressively. Activate dialysis. If intubation is unavoidable, match the patient's high pre-tube minute ventilation immediately with bag mask, then ventilator settings that mimic their spontaneous rate and volume. Any pause worsens acidemia and pushes the drug into the brain. The board trap is standard ventilator settings after the tube goes in. Question 1. An opioid overdose patient is apneic. What is the first life-saving action? The answer is to ventilate the patient with bag mask, then give naloxone. Ventilation, not medication, is the immediate life-saving intervention. The board trap is reaching for naloxone while the patient is not breathing. Question 2. A patient has visual symptoms, severe anion gap metabolic acidosis, and an elevated osmolar gap. What antidote do you give? The answer is Fomepizole. Do not wait for a confirmatory methanol level in a deteriorating patient. The board trap is delay for laboratory confirmation. Question 3. A tricyclic antidepressant overdose patient has a wide QRS at 140 milliseconds. What is the treatment? The answer is sodium bicarbonate 1 to 2 milliequivalents per kilogram intravenous bolus. Repeat for QRS over 100 milliseconds. The board trap is using antiarrhythmics instead of bicarbonate. The final takeaways are these. ABCs and glucose first. Toxidromes guide therapy. Opioid endpoint is ventilation. Salicylate intubation is catastrophic without matching minute ventilation. Tylenol 4-hour level on the nomogram drives NAC decisions. Toxic alcohols need Fomepizole and often dialysis without waiting for confirmation. Calcium channel blocker and beta blocker overdose. Calcium, vasopressors, glucagon, high-dose insulin, lipids, ECMO. Sodium channel blockade gets bicarbonate. Digoxin toxicity gets Fab for instability or hyperkalemia. Poison center early. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, Gold-Frank's Toxicologic Emergencies, 11th edition, the American Association of Poison Control Centers Position Statements and Treatment Guidelines, the European Association of Poison Centers and Clinical Toxicologists Guidance, and the Extracorporeal Treatments in Poisoning, XTRIP, Recommendations for Dialysis Indications. The Rumack-Matthew nomogram remains the foundation for Tylenol treatment decisions. Local institutional protocols and your regional poison control center guide site-specific care.